Good morning and welcome to our first, or actually final, panel session of the Technology Association of Oregon's Health Tech Summit. It's a conversation about the future of healthcare and the advances that are transforming clinical and business processes within the healthcare system. I'm Skip Newberry, President and CEO of TAO, and I'm joined by Riley O'Brien, who's our VP of Events and Experiences. She'll be providing back-end Zoom support. I'm going to go through a couple of logistical items before we get started. All participants have been muted, and we'll ask that you please remain on mute unless a TAO staff member unmutes you and calls on you to talk. You may ask or respond to questions in the chat box publicly or privately by directing your message to me or to Riley, who is under the name Special Events. We'll monitor the chat box and respond throughout the discussion. We'll also ask you all to engage via the participant icon on your screen. We also want you to engage with us over social media during the call and throughout the day. We love to share what's happening at TAO and to get participant takeaways from our events. We also encourage you to join us today at noon for our second and final innovation showcase, which will feature up and coming health tech companies from Oregon as well as Israel. A big thank you to Otradi OBI and the Israel Consulate General to the Pacific Northwest for helping to support our 2 days of programming for the Health Tech Summit. We appreciate your support and are excited to explore topics related to digital health. And finally, it's my pleasure to introduce our moderator for today's conversation, CEO of LightPoint Northwest, Molly Moore.
Hey, Skip, thank you so much. Thanks for the opportunity to speak today, and thanks to the sponsors and your whole team for putting such a great event together. I am Molly Moore, as CEO of LightPoint, as Skip already mentioned, and we are an IT provider. We do outsourced IT services in the Pacific Northwest, mainly focused on healthcare, which is why I've been asked to moderate today. So I'm thrilled to be joined by such an esteemed group of panelists today who are really providing such a broad range of experience and expertise and background around AI and data. I will introduce each person. They'll provide a little bit about their background. We'll keep that really short and sweet so we can kind of get to the heart of the content here. But we have our panelists representing the healthcare system view, and that's from Ryan Harmon. He is a data engineer at Legacy Health. Ryan, do you want to provide a little bit about your background?
Yeah, sure. Ryan Harmon. I've been with Legacy Health for about 11 years. Currently, I am their principal BI engineer. I've actually been dealing with data in multiple ways for, way too long now, well over 20 years. So bit of experience with this and kind of a data junkie with this whole thing. So anything around AI or these kind of solutions, I'm definitely enjoying.
Wonderful. Thanks for joining us. And then secondarily, we have Tayoatkins, and he is providing kind of the payer health insurance perspective from about AI. And Tayo, your background, please.
Yeah. Good morning, everyone. My name is Tayoatkins, CEO of Cascade Comprehensive Care. We focus more on the Medicaid and Medicare population around the payer space, based in Klamath Falls, Oregon, Southern Oregon, home of Crater Lakes. Go.
We represent the Southern Oregon establishment. Thanks for joining. All right, and last but not least, Matt Hollingsworth. He's the CEO of Carta Healthcare, who is a local Portland-based company providing AI solutions for healthcare. So he'll bring a really great perspective for us. Matt.
Hi there. Great to meet everyone. I'm Matt. Started off as a high energy physicist, spent 6 years at a lab called CERN in Switzerland as part of the team there that found a particle called the Higgs boson, and I've been doing data science for my whole career, generally as an engineer, and now as the CEO of this company. Specifically what Carta does, we built AI to help reduce the data abstraction burden for collecting data, specifically with a focus for data that can really add value to the organization. So things where collecting the data will help unlock operational potential as well. So the two sort of sides of the business are collect the data in ways that previously required a lot of manual labor, which you can now do with AI. And on the other side, use AI to derive sort of operational insights and predictive analytics. So that's sort of the company in general. And looking forward to the discussion.
Me too. Thank you, Matt. So we will throw the first question at you because of your background. I know AI is kind of a term that is used broadly, and there's a lot of different definitions, but kind of in the most simple of terms, the ability of machines to simulate human intelligence. But I guess, how would you define it?
Yeah, great question. So I think that is the perfect working definition for AI. Generally, people get hung up on AI versus machine learning. I think the right way to picture that is as a Venn diagram, where machine learning is a particular class of algorithms that can implement AI. Generally, they're of the form more data means better performance. That's sort of the general rule to think about there. So if you pour more data into a machine learning algorithm, it will get better and act more like human-like intelligence, which is the sort of AI part of that Venn diagram. Honestly, I wouldn't get hung up too much on that. Like for people, like the real thing that is interesting is when an algorithm can replicate or enhance an existing process. That's really where the innovation lies. Because a better working term for all of the things that is really the more recent advancements that are cool to talk about is, I would actually use the term applied statistics, which is like, sounds less sexy to people, but that's actually what it is. And like that is really where because also you could say AI, like if you had a text box where you had 1 + 1 and it spit out 2, like AI is kind of a useless definition insofar as like that would actually meet the criteria for AI. Like, could a person do that? Yes. Could you tell the difference between a computer and a human doing it? No, therefore it's AI. So really more interesting thing to think about is how big data, when coupled with really innovative statistical processes, result in a human-like system. And that's really what people mean when they're talking about AI, not just like a processor that can add 1 + 1, even though that's technically AI by the typical working definition of it, is really how we can use applied statistics coupled with large data sets to simulate human behavior. So that would be the working definition I would use if I were all of you. The rest of it's just implementation details that are less interesting.
Great, thank you. I did a little bit of research prior to this session, and it really is amazing how people are leveraging AI in such different ways. And so really like to now dig into with Tayo and Ryan a little bit about how is your organization leveraging AI today, kind of where do you see that evolving into the future? Tayo, let's start with you.
Yeah, so thank you so much, Molly. So from an AI perspective, we believe just AI is just literally how do you use it to enhance your analytic capabilities? So I'm in the business of managing risk, both financial risk and clinical risk. And it's to Matt's question, at the end of the day, what is AI for us as we look through it is statistical analysis, right? What is happening? Forecasting, what is the trend? Predictive analytics, and what is the emerging risk that I need to be aware of? And then obviously optimizations. So if I can use AI as a form of competitive advantage to understand that from a clinical and financial risk, that gives me a lot of edge to allow us to do a lot of great things for our members.
That's great. And so do you see can you expand further kind of where you see your evolution there going?
Yeah, so in terms of evolution, so you look at it in a couple of ways. So I mean, there are multiple, and I'll give you a quite example. We literally invested in a particular company called Eon Health. It was Access Mobile before they rebranded to Eon Health. And when you look at Africa, for instance, they were literally in Africa, and then you look at the high penetration of mobile payment in a country like Kenya, for instance. And one of the things that we really realized, and it was the same question we're trying to solve. What is the problem we're trying to solve around AI? It's the problem. If I don't have a problem and AI cannot solve it for me, it's useless. So one of the things that we realized is around quality metrics, both on the Medicaid side and on the Medicare side. So around quality metrics, how do you activate and engage your members, right, in a way that they can show up and see their doctor? So there's just this number that, oh gosh, you know what, you have to do something. OHA will give me a particular incentive to do certain things for my member. But at the end of the day, the member have to show up to see their patients. And I have a significant amount of no-shows. At the end of the day, if a member doesn't show up to do what they're supposed to do, or we activate and engage them in a way that it's meaningful and text related to their particular perspective, it's just meaningless. And so when we invested in the tool and use a lot of, text is one efficient way of engaging a lot of our members, especially the low income. There's no download required, it's just texting. And so we use that to literally engage, activate them, and obviously increase our adoption and minimize our no-show, and obviously improve our quality outcome.
Excellent. That's looks like you're doing quite a lot there, and excited to hear more about that as we dig in here. But let's transition over to Ryan. Ryan, representing kind of the health system side of the world, tell us more about how Legacy is leveraging AI today.
Yeah, so Legacy is a large hospital system, so I can't speak for the organization as a whole. I am aware of some AI work being done by our research department for early eye disease detection. But my perspective is more around the business intelligence side of things, the core database environments. And currently our use of AI is very limited. We've attempted some AI projects in the past, but that just showcased some issues we had around data governance. So because of what we showed there, it kind of highlighted this need for a data governance and set a priority around it, and to get that up and running first. But we are utilizing some third-party data solutions with our own data models that are using machine learning. But within our BI department, we've just started looking to some low-code solutions, more around AI and data insights, hoping that progresses sooner than later. But first, what we need to do is get our data governance in order. And then from there, that'll progress more into a much larger, or hopefully start getting more of those AI projects that we want to start pursuing here soon.
Great, thank you. And I know we are going to talk a little bit further in a little while. I know Matt has a lot to say about data governance, so we'll jump into that in a bit, but thank you for that perspective. And Matt, so I want to ask you just a similar question with a different spin is, how are the healthcare organizations that you all are working with, how are they leveraging AI today, and how do you see that evolving?
Yeah, so I haven't seen So just for background, our company was essentially, my co-founder and I were researchers at Stanford. And so generally they are at Stanford Healthcare specifically. So they're generally fairly they lead the pack for the most part in that regard and things like that. The whole time I was there, unless it was our group that was doing it, we were part of the healthcare operations group. There were very few, let's say, live AI implementations there. And it gets down to just as Ryan was saying, the data governance issues. And there's a lot of questions of liability, for instance, when you get these things involved, that it's such a long list that it's very difficult for institutions to start really engaging it in, especially in the patient workflow. That's like a nearly no touch zone for these sort of technologies, with a few exceptions. But the places where it exists are things like revenue cycle management, or things that are out of band of patient care for the most part. So I don't think I've seen any non-experimental live AI things that were not from our company at this point, in the particular actual care pathway and the that wasn't under revenue cycle management. Now the reason that we have been successful in deploying it is because we bear all the risk for all of the AI components, and there aren't many folks who do that essentially. And I think that's predominantly why that has happened. Now there are lots of great technologies out there, and I should caveat this: we work exclusively with large health systems, which is a different ballgame than all the rest of healthcare that can move a little faster. But just the key takeaway here is, I was right in the middle of a lot of the research going on for this. And the biggest barrier by far are the data governance issues, and just the general, the risk tolerance being very low, and rightly so. You don't want an algorithm killing a patient because you gave a wrong recommendation for a drug or something like that. And people are very leery about that. So my key sort of takeaway there, I think, for that would be for folks right now to focus on cases where, and of course it's coming from a technology company wanting to roll things out, or this also applies for internal groups as well, I think, but a little less directly. But finding a way to bear the risk or mitigate it so much that it's not scary to people is the single most like good predictor for success for an AI project, because it's such a black box to people and they don't want folks to die, which is a pretty legitimate stance in my opinion. So it's something you have to be really careful about. And that's why we focused on things that essentially, when the AI performs better, all the outcomes that are related to the work we're doing are better, but the baseline is the old steady state way of doing things. That's like a short summary. Maybe I'll get into more details about how that works exactly later, but like giving everyone faith that it will be strictly better than what's there and that they can observe that is a really important product design question for this, because it's very rarely about tech. It's almost always about adoption and risk tolerance.
Absolutely. And so the data governance piece has kind of come up a couple of times here. So I'd like to ask Ryan and Matt to address that. What specifically do you need to work on with regards to data governance? What are HIPAA compliance things, if you will, related that need to be addressed in advance of launching into AI? Ryan, do you want to go first?
Sure. So actually got a little story with that, because a few years ago, we had actually started an AI project with Microsoft based on a patient's length of stay. So I thought this was going to be a fairly easy one to kick off, straightforward concept. We should be able to get something started right away. And when Microsoft's data scientists came to meet with us, they asked us some fairly simple questions first, right? Like, how do you define a patient's length of stay? And where would you get this information? Those first questions is where easy ended. As what we found is that there was more than one definition around length of stay, kind of a clinical versus financial versus discharges versus readmissions. And this discussion progressed further. We found even more interpretations around the data that we thought was so straightforward. So what this project actually highlighted or showcased very clearly was that we needed data governance. We have departments that understand their data very well, but that knowledge wasn't shared across the organization. So the bright side here for us, that it highlighted some of the legacies, wide improvements needed to make around that data education and that governance piece, and to make this a priority. So, and we actually tried to continue this project with Microsoft. And one of the things that we did find was a showstopper for us is when we found out that this project was being done with multiple organizations, where the data was combined to build out a much larger model. So like as Matt was talking about, the more data, the more efficient the model is, the more reliable the results are. And Microsoft assured us that the data was going to be de-identified and that was covered under the DAA, but that had us pull back and pause. This would have been our first time actually sharing data, any kind of data in a cloud-based solution. So for us, it's a little scary. And we had to go back and ask questions. We needed to look into this a lot more before we could say yes to this. Since this was going to take quite a bit of time, that was something that Microsoft said, we got to move forward with this. We understand. They actually had other organizations kind of pull out for the same thing to look into that HIPAA compliance to make sure. Since for any hospital organization, legacy is the same way. Any kind of patient data, anything out there being exposed is extremely important and extremely critical that we make sure that it's as private as possible. So we did have to pull back on that for that HIPAA compliance piece. But this whole project, it highlighted that need for data governance. If we had a data governance in place where we could catalog, classify, and set up that data in a way that was easily distinguishable for any of these definitions, we might have been able to move forward with this project. We might have been able to move forward faster. And this is where we are putting our efforts into right now, getting that solution set up, that cataloging solution set up. So as we want, or when we want, or hopefully soon, when we're able to jump into those AI solutions, we're going to be ready for it.
Matt, this is probably a story you've heard before.
Yeah, and I'm so glad you used the case for the length of stay thing, because I can tell you the story on the other end. I wasn't at Microsoft, obviously. This was another thing at Stanford. And actually, you're also kind of pitching my company in some ways, so I'll get into that in a second. But so the second project that I did at Stanford, for folks who like reading papers, if you just Google Target-Based Care and Google Scholar, you'll find it's the lead author is a guy, Dr. Shin, who's an advisor to our company now. I was part of the SURF program, the healthcare operations group at Stanford. So the thesis behind that, and this is just to show, okay, for folks not familiar with why length of stay prediction is interesting, that paper, Andy's an excellent author, highly recommend reading it, because this is just a poster child for why that has such a huge impact. Just to cut to the chase for that, by knowing the length of stay in advance, so that paper is specifically focused on cardiovascular surgery discharges into the CVICU, acute care, home. So the three things that were being predicted were the time for discharge, extubation, discharge, CVICU, discharge to home. So those were the three things that they were predicting. Just by putting that at the foot of the patient's bed, they reduced the length of stay by 35% because the whole clinical team was engaged and knew what the goals were. And it worked flawlessly. And how did they get that data? Dr. Shin, a cardiovascular colleague of his, and a graduate student together collected data by hand from the EHR, because there was no data governance. They couldn't just like query to get those three parameters. It took them 6 months of labor, and to collect, this was for 400 patients. They typed it into RedCap. They calculated the medians, they slapped it at the foot of the patient's bed and reduced length of stay by 30%. Now, there are lots of interesting things in that story. But one of the key takeaways is, I think a lot of people think that EHRs mean that you can like ask questions about what happened to your patient clinically. No, you can't. Like it's all billing aligned data. The only way to get at that information is to abstract it by hand, by and large, or put a huge amount of effort into upfront structured data, which is still data abstraction. It's just the frontline people doing it, which is worse, instead of the like downstream nurses. So those are like the only two options in the sort of current state of affairs. And that's why what our company does is slap AI in the middle of that, read through the clinical notes, and fill out registries. And so another term, like one of the core sort of things I want to get across to people who are sort of interested in the space of data governance and the like around healthcare, is that registries are a wonderful data governance framework because they've had clinicians look at it. They have excruciating detail in terms of definitions, and they're captured at thousands of institutions across the US. So it turns out, like, for instance, you can go take the stuff from CAF-PCI, one of these registries, and build these predictive models for length of stay, and it will be the same at every institution because it's such a hard definition. So being able to collect data into those registries is one of the ways to solve those data governance problems. But like Ryan's story, like, we lived that from the other end. Like the answer was, you can't get that information from the EHR in a reliable fashion. You have to have someone come through and abstract it. And the way they do it is they look at the discharge notes, figure out when the patient left, figure out when the patient was extubated, and type these things in by hand into a system. So the key takeaway from this story, there's like a lot of moving parts there. It's pointless to think about AI if you can't feed data to it. And if you can't get a big enough data set from a single institution, chances are your project isn't going to work, just because of what Ryan just, like, that story has played out millions of times and has killed 95% of the companies that try to operate in this space. I mean, it killed Microsoft's project. I happen to know the people at Microsoft who were doing that. Like, it went nowhere because people didn't care enough about the data governance up front and try to pre-plan that before they put a bunch of resources into the technology. So please, for anybody who is running these projects or is a technologist or something, ask those questions first so you don't waste your life, because that's what's going to happen. If you don't ask the question first. It's of existential importance for all the AI endeavors. So anyway, sorry, get off my soapbox.
That's great. No, thank you, Matt. Awesome. All right, shifting gears just a little bit. Tayo, you spoke a little bit about this in an earlier question, but talking about the impact of AI on the payer side of the world. Can you expand a little bit more around your perspective there?
Yeah, so from a payer's perspective, when we think about AI, it's literally how do you use data to make precise decision, better decision. And when you're in the insurance industry, so we look at it from, at least let me speak for ourselves. We look at it from a clinical risk and a financial risk. And can you use data to change behaviors? So if I don't have enough data to change behavior, that's modification of behavior. Or if I don't have data to help me understand emergent risk, where I can have some elements of intervention around some of my members, that becomes more crucial. So when we think through AI and when we think through some of the clinical platforms that we've invested in terms of modeling, one is allowing us to be smart enough to make decisions based off on rich data that allow us to make action, that allow us to take actions. One, from an intervention. Two, to help the member get better. Three, on the value-based payment, we can talk about more about that. And I completely understand around data governance. The fact that I know about the data does not mean I can share the data anyhow. There's HIPAA compliance around with that. You know, specific example, doing a disease management, for instance, members who are diabetic. There's certain level of data governance that has to be in place for me to target my members regarding their disease type. So the message and how we communicate that message to the member becomes more relevant. And that is truly around our data governance as well.
Great, thank you. And Matt, so you've mentioned a few examples, but can you share some additional use cases you've seen just from the, kind of the healthcare worker, doctor perspective for AI?
Certainly, yeah. So I think the highest value ones at this particular point in history are largely operational. So like one thing that one of the papers that I wrote with actually Andy and another professor named Dr. Schenker, like using supply chain data to predict what an optimal preference card is in the OR. It saved Stanford $3 million a year. It was a fairly simple project. Again, had a data abstraction barrier, which is part of the reason why our company exists. But like sort of to Tayo's point, like one of the key ways to derive value. So first off, you heard my soliloquy or whatever you want to call it on getting the data in the first place. That is the most important thing. After you have the data though, generally the things to go after at this point that are highest value are operational improvements that sound something like, supply chain, or like there's an overhead of X that could be reduced with technology or what have you. So like right sizing preference cards is a good opportunity. The length of stay, like not having people stay too long. Like for instance, one of the things that came out of the paper that you saw there is better case manager staffing, which to folks who don't dig into the weeds, that sounds tangential, but what happens in real life is like, people's health is not follow weekday schedules, like they're ready to discharge at whenever they're ready to discharge, 9 a.m. on Saturday or whatever. If you don't have a case manager, then you get an extra 2 days of stay, which means that your surgical throughput drops, which means that your bottom line drops, and that's bad for everybody. And also you get to see fewer patients. So like these sort of operational improvements are something that AI is spectacular at doing. So, I mean, I think that's really where a lot of the value is. So like some of the things we've done, for instance, surgical block optimization, anesthesia coverage optimization, the preference card stuff that I mentioned, preventing SSIs by figuring out contributing factors in advance and addressing them. Like there are all kinds of cool stuff that you can do. Sepsis prediction, don't use Epic's module. Well, I shouldn't say it too loud, but there's like infinite things that you can do as soon as you have the data to drive them. But the key takeaway there, make sure you have the data to drive them, and don't just do it because it's a good idea, because in healthcare, there's like a 98% chance that even though it's a good idea, entrenched interests and sort of change management is going to kill it. So like Wizard of Oz it first. Like if it's again, AI is about sort of replicating human intelligence, and just drop humans in there at the beginning, make sure that people actually want the thing you're building. If that works, then chances are the tech will work if you have the data at this point in history, because like AI is so far advanced, like it's left healthcare behind, like for, it's a decade behind at this point. So like for the most part, the low hanging fruit that you're going to find that actually will be adopted, the tech isn't going to be the barrier. So just make sure that people actually want it first. That's really the key. But one of the easiest ways to do that is to focus on operational improvements that don't lose people jobs and like, get unions involved and stuff like that. This is all like real things you need to worry about.
Great, thank you for that. Ryan, how about you from the administrator side of the house? Do you see a future of AI?
Well, I got to go back to, once again, this kind of get a little repetitive, but it's the governance There is a lot of time and effort that's involved in there to make sure that as we move forward with the AI experience or any of these new solutions that help us process data, that data is correct. So, a lot of these things, what we thought was going to be a relatively straightforward and simple definition was simple because that was our definition. It wasn't an organizational definition. So this is where for us, the majority of our time being spent as a data engineer is around that the governance piece of this. And even for us finding a solution that would house this data, had to house that data, the data governance options, was very limited and very difficult to even find. It seems that they've just recently come out, and it's been a priority just over the past few years. So either the solutions have been way too expensive or way too cumbersome, or even doesn't actually apply to what you truly need a data governance solution to truly do for you. So for us, before we can get into the AI on the administrative side, before we can actually start doing anything with those new prospects, is to get that data cleaned up and to make sure that going forward, we have a simple way for people to start using that data and to trust what they're actually going to use those solutions for.
Great, thank you. So I think now we want to shift a little bit and talk about, how do you first get an AI program going? We talked about the governance. We talked a little bit about, what do you want to solve? What kind of question do you want to answer? And do people really, need to spend a lot of time kind of working through that across the organization to determine like that's the thing. Tayo, do you have a perspective on this?
So I think I'm going to piggyback on what Matt said. I mean, this is absolutely true. I happen to be. So when we think about AI, literally is what problem are you trying to solve? What is the business case? So is the value of AI and the benefit of it outweigh the cost of implementing it? That's number one. If it's greater than 1, 2, 2x, 3x, that's the first checkbox. The next checkbox becomes the technical complexity around AI, right? Do I have the data relevance around the data? Meaning, do I have the data that I need, to what Matt was alluding to? Where am I sourcing my data from? Do I have the set amount of quantity of the data that I need? And what is the quality of the data do I have? And is it right? Is it accurate? And is it reliable? And the last one, obviously, which is absolutely crucial, and literally our compliance officer will literally stop us at every given point, is the data governance. Do we have the set of right processes and rules in place to use the set of data? The fact that I know that you're diabetic does not mean I can contact you. So that's number one. So those are technical complexity. And then the third one, it's I think Matt said this, is organizational readiness. The change around it becomes more important. How do you align your stakeholders so that they have a buy-in into the adoption? So literally the risk has to be very low and it has to be very easy for people to adapt into it. The moment the data is wrong, providers, especially my clinicians, are going to challenge every last one of the AI constructs. So in my mind, as we look through as the impact, is the business case sound? Yes. Is the technical complexity low or has been mitigated? Yes. And is the organizational ready for it? And that is the crucial part. You can have a strong business case, technical complexity low. If the organization is not ready for it, it will die. But I happen to be in a fortunate situation where I'm driving it, so which is a little bit different.
Well, there's two things I want to dig into that Tayo brought up. One is, how do you gain that adoption inside your organization? Matt, you've probably seen projects that have failed because there wasn't adoption, and then the opposite. What can you share there?
Great. Yeah. So I think everything that Tayo said was spot on. Let me to just give an example about a failure mode here, just with the story, I think is the easiest way to explain So like imagine like one of the things that we can do is based on past performance and an existing block schedule in the OR, spit out what is a performance optimal block schedule. So in theory, like that should just happen. Like, I mean, it's one of those things where the pitch to the management is literally like, make this change and your bottom line, or like whatever you want to measure, revenue will go up by like 10%. It's like a real life scenario, really will happen. So very clear, and we're talking like, you know, multi-billion-dollar revenue institutions. That's a valuable piece of paper, right? That you can print out for that. So that should be the world's easiest thing to implement. Except in real life, what happens is you bring that paper into the block management committee at the hospital that is populated by predominantly surgeons. And what will happen is say that the answer is this guy has 40% utilization and this one has 70%, therefore give the 70% guy an extra half block and take half a block away from the other guy. That doesn't go well. And it turns out because the surgeons run control the bottom line of the hospital, if it comes down to surgeon leaves or you have a suboptimal block schedule, you'll have a suboptimal block schedule. That's simple. So it's one of those things where like, if building those algorithms takes a really long time. And so what you need to do to make sure you don't waste time on things that don't matter is provide, like, sit down like a consultant, work with them, figure out what they want to hear and what will get to the best outcome, as opposed to what is like if you're, I mean, I've been an AI engineer for my career. Like if you just tell AI engineer like, hey, this is suboptimal, optimize it, that piece of paper that's talked about, what comes out, that's not actually what the surgeons need. What they need is the ability to play with it and understand their impact. And you get a totally different product design. Still uses AI, still results in a true optimum, like an actual attainable optimum, working with that. So like giving them the tools to iterate on it and understand the impact of their decisions is what they actually need. So it's one of those things where like people who are really good at AI are often really good at optimization. If you just give them the problem, they won't get adoption because the way that it's implemented, the way it's communicated, the product design that comes out of it just doesn't work. So the way to drive adoption is to do it, like basically do it, become part of the team that you're trying to help them, and then do AI for it. Because again, like for the most part, these things you can all, like I haven't run into a single project that is, I'm sure there are projects that you can't do this for, but almost all projects, the right way to do it is to sort of Wizard of Oz it, where you go and you optimize it by hand yourself, like in a way that will work. Or like when they say, well, this isn't helpful to me, like I have clinic on that day, it doesn't matter if you want me to move that block, I can't do it. Then, okay, let's do this. And you do it as a conversation. And what will come out of that is an actual usable product, which you can then go implement fully. And if you're like building it in-house, then roll it out. If you're an external company, sell it. You know, an important note there, for the external company crowd, you should always sell your contracts before you've written a single line of code. If you don't do that, you will fail. That completely sure about that. Like there is nearly no exception to that. There are a few, but not many. For the internal folks, it's a little easier because it's easier to hop onto the team because you don't have to sell a contract or whatever. You just go and say, hey, I want to help you guys, you know, have a better schedule for everyone, and the results will speak for themselves afterwards. But the key takeaway here for the adoption is to do it first yourself with the minimum amount of technology and make sure people actually want it. That is always the key to it. And also go in understanding there's a 95% chance it's not going to work because entrenched interest or whatever. So.
Okay, so if there's a 95% chance of it not working, I'm just trying to put myself in the shoes of maybe some of the attendees here, like why do it?
Because that 5% can revolutionize everything, like in a very positive way. The remaining 5% is like, I mean, I get there are lots of ways to look this up, papers, everything, but we waste a third of our healthcare dollars. And like pretty much everyone agrees at least that. And you can give patients better care for a more affordable price by going through the process of chewing through these things. Now, when you do it without writing a bunch of code, you can go through these. I mean, we did dozens of them in like a couple of months trying to figure out the right ones to do. So it's not something that you have to like, your experience will not be, at least on a statistical basis, will not be like constantly running into walls and never seeing success. You will see success if you keep doing it. But I'll tell you what's much worse is to pour your life and soul for 2 years into some awesome system that works and does everything that it was intended, and then nobody uses it. So like, I would say that there is a huge amount of upside potential for it. All you have to do to realize it is be willing to try different avenues until one works. Which is not as bad as it sounds, but it's bad for the people who just want to write algorithms. But like, you're probably not going to be successful if that's all you want to do, or you'll have to like glom yourself onto someone who wants to do that essentially. So that's it. But it's very much worth it for the impact. I mean, just like those papers that I was citing, just read those. It's like it's incredible what it can do if you spend the time on it.
Excellent. And Tayo, you brought up the ROI, and this could go to any of the panelists here. You know, how do you work up the ROI for this in launching a project around AI or a program?
So from an insurance perspective, I mean, Matt hit it that bottom line. Yeah. So is the business case, is this impacting a couple of things? Revenue? Is it allowing me to reduce medical expenses? Is it allowing me to identify hidden risk within our members so we can do intervention to lower my medical expenses? Is it allowing me to improve member satisfaction, which is also great? Is it allowing me to reduce no-show because I have an incentive to meet a quality measure, both on the Medicaid side and obviously on the Medicare side, so that my members show up in the clinic, right? So on the bottom line, so so that's the business case for us, right? That is truly the business case. Is it impact? Is it one, am I improving quality outcome? 2, am I improving revenue? 3, medical expenses. 4, member satisfaction and well-being. And at the end of the day, if we do it well, I mean, transformation of AI, and I know it's a mega trend, is can we reduce costs and improve life expectancy in a very meaningful way? That is the power of AI.
And it's hard to put a dollar figure on
it. It is hard to put it. Yes, that's correct.
Absolutely. Okay, great. Thank you. So I'm just curious from your perspective, probably Matt, in terms of if I'm a smaller healthcare organization, let's say, you know, I'm a 5-location pediatric organization. Is AI applicable to me today? You represent and work mostly with larger health systems, but you know, if there's a CEO sitting on the call here today, you know, are they thinking we're 5 years from AI really being applicable to my organization, or how would you respond to that?
So I think I'm less knowledgeable about that space because it's such a different challenge. So like what's hard about health, like large health systems, there's pros and cons for large health systems. So moving the needle, you know, frankly, like moving it 1/100%. Like if I could come in and pitch to someone and they actually believed it, that I would impact their throughput by, let's say, 0.1%. If I would increase their surgical volume by that, it would be rational to pay me like, you know, $5 to $10 million for these normal institutions. You can easily build a company on that. And so like from some perspectives, it's a lot easier to build those because the impact, like it on a percentage term, the sort of realm of rational investment is much larger in some ways. What that comes at a huge cost though, that is all the data governance issues that we were mentioning. Like they're huge institutions, they move very slow, so the sales cycle is really long, and like the implementation cycle is just as like has the same length of time expansion. So because of that, the expense for rolling things out is inflated significantly. So essentially the optimal for the smaller institutions is something that has a lot lower lift to integrate. So like something that only needs Fire, for instance, to integrate with, and after you have that, you're golden, or like some of so there are solutions for it. And then the other piece though is in order to make the ROI work, the percentage of impact has to be smaller for those institutions, just because like it's really hard to build a health tech company on like sub 10K contracts. Essentially it can be done and folks have done it, but it's hard. Like it's just the space of problems where that works is a lot smaller than the space where it doesn't. So I would say it definitely is impactful. I don't know for sure, like my gut is most of where the impact is going to fall there is in revenue cycle management and like operational things like that. But I don't know the space well enough to give specific examples. But I do know that for sure it would. It's just the like balloon is squeezed in a different direction in terms of like what's hard versus what's easy. So
okay, fair enough. Thank you very much. All right, moving on. Let's talk a little bit about the downside to using AI in healthcare. Ryan, not to put you on the spot here, but do you have thoughts as to kind of what could be a negative impact? Obviously, I think it was Matt mentioned earlier, making a wrong decision about a patient care and could be very impactful, but are there other things that you're aware of? And then I could ask Tayo and Matt the same question.
I would say resources. So a lot of healthcare systems right now are stretched thin as far as resources required for something like this. So actually trying to get well, I guess there's resources and there's expertise around this as well, because that's also something that we're having a difficult time finding is the actual people that you can bring into your organization that can actually start these projects. And at the same time, trying to showcase the benefits of the project so you can get these people in. So a lot of that is where we're struggling right now is the actual expertise and then showcasing the need for these people to bring them in so we can actually start some of these projects. Not necessarily, I guess, a negative to the organization, but for the people that want to actually start these projects, it is tough. It is a challenge that we're trying to look at and trying to overcome.
Yes, it still is a relatively kind of new area, and finding expertise, particularly in this labor market around anything, let alone kind of a new industry, is I'm sure quite challenging. Matt, I'm sure you deal with that every day. Tayo, what else would you add to that? What do you see as some of the downside in leveraging AI?
So Molly, just a little plug. So Ryan, just in case you're looking for talent, OIT has a significant amount of talent, just in case. I build my BI team just based off an OIT grad. So just say FYI.
Excellent.
Now, just coming back to, I think there are a lot of, AI is a mega trend. Everybody talks about it. But at the end of the day, if you believe your organization or your competitive strength is around data analytics and data capabilities, it becomes one crucial thing. The downside around AI, and as we talk about this, at least within our organization, is ensuring that we don't have bias in data. That is the biggest part where we have to stress test all our data from a quality. Yeah, you have the quantity of data, but do you have quality data, and is the data biased? Because whatever you feed into your AI tool is basically going to spit you out the same level of bias that you have coming in, right? And I think that is the biggest part as we think through AI. From an SDOH perspective, we talk a lot about this, is how do we ensure that our decision-making process does not have any bias in it. We all have a sense of bias. The question is, let's catch it and let's validate it before we feed it into an AI that we use it in making a decision.
That's a really good point. And Matt, and I imagine I know I did some research again, and kind of this thought that we're reducing human interaction in healthcare is something that comes up a lot around AI. Do you have other thoughts?
That was effective. So my take on this, so for folks who don't know these sort of statistics, typical large integrated provider spends between, on the very lowest end, 50%, but more typically 70 to 80% of their operational spend is on labor. And so when we were all saying before, like one of the big impacts that AI can have is reduction in medical expenses, at the end of the day, that means someone doesn't have a job anymore, just to be blunt. That's like, because a lot of these things are being plugged with people, like the problems that AI can solve. And so that's the biggest risk is change. And that's why I keep like change management as a broad picture, like having a harder change management story by integrating AI, I think is the biggest risk. So like when grilling people on projects and vendors or whatever, they need to have a really good answer for how that will be managed, or it can cause a labor problem. And I wasn't kidding about like the unions and stuff like that, like putting nurses out of jobs or like it has real, I mean, sometimes you just can't do it. So like, it's one of the things where like, yes, it could theoretically reduce cost, but if your nurses are going to go on strike because of it, like not worth it. That sort of stuff has to be priced in. So the risk, that's a big risk if not managed. Now, like people who know what they're doing will have a solution for that. Like we thought about that in excruciating detail and have an answer for how to deal with it, but like not all things have a clear answer. Like if someone comes along with something that can read radiology images and replicate radiologists, and then you don't need them anymore, like that's not going to go over well. And it's so you have to just be really, really careful on that front. I think that's the biggest risk by far, at least in what I've seen.
Well, that's why we have organizations like the TAO to work on workforce strategies for us, right?
That's right. Exactly.
As we're coming close to the bottom of the hour here, I just want to remind the participants, if you have any questions, feel free to throw those into the chat window and we'll try to get to those. Matt, you said earlier that AI has left healthcare behind. And you're welcome, Skip. What can healthcare learn from other industries that have adopted AI more rapidly? And Matt, do you want to address that first?
Yeah, sure. I mean, I think the key is that it can be done. Like, there's not anything that is fundamentally more difficult than in other industries. I mean, healthcare is a complex, but still fundamentally logistics problem. Like, you need to get people in the right place at the right time, prevent adverse events and the like. This could be done. It really can, and the harder part is all the change management stuff that we mentioned. But I think one of the key barriers to that change management piece is just people feeling like it can't be done, or like there's something special about healthcare that makes it impossible or something. That's just not true. So, I mean, I think the key thing to learn from other industries is just like stop asking that question and start focusing on the actual barrier. Like, I think that if you were to just poll healthcare workers and ask like, what is the barrier for AI adoption, they'd all say it doesn't work. And because that, like, at the end of the day, the goal is to climb the mountain. Usually where it dies is on the change management canyon, but that's not visible to people. All they see is I kicked off the length of stay prediction process and it failed. Microsoft doesn't know what they're doing, is what everyone walks away with. That wasn't like in the weeds on the project, which is most everyone, because again, healthcare is complex from an HR perspective. So I think the key takeaway is stop feeling like it's special. People analyze the wrong axis. It's not the technology that's the limiting factor. I've never seen that be the case. I'm sure there are projects where that's true, but I've never seen it. It is almost always the change management piece, and I don't think people focus enough time on that and go in eyes wide open on that front. So.
If people didn't hear the words change management and data governance today, I don't know what to say. Tayo, would you have anything to add to that?
So sorry, can you repeat the question? Sorry, I
just what could healthcare learn from other industries adopting AI more rapidly?
A lot. Sorry. Yeah, thank you for healthcare can learn a lot. When you I'll use the casino industry, very rich in data, and the question becomes, how do you use data to optimize and strategize and predict what's going to happen next so that the houses doesn't lose, right? So when you now transfer that set of thinking around using data as a core analytical tool to enhance your competitive advantage, that becomes huge. So when you look at the US, for instance, I think I just looked this up yesterday, I believe our healthcare expenditure, it's about 18%, and that is about $4 trillion. And in 7 years, in 2028, that is supposed to go to about $6.2 trillion, 50%. AI has the capability of transforming the industry by reducing that cost, increasing life expectancy, and still give a high quality outcome. And the question becomes, and to Matt's point, is healthcare is complex, but is driven by policies. And as long as policies are involved and legislators are involved, it's the change management from a health policy perspective is always going to be there. And obviously the change management from displacing workers or trying to allow workers to think differently in terms of using BI and business intelligence as a way of being competitive becomes a reality that we have to face.
Absolutely. Thank you, Tayo. All right, well, we're getting close to the end here. I just wanted to throw out to the panelists if there was anything else that was on their minds. I didn't ask them today that they'd like to share with the audience here around getting started, or where do I go find more information, or any other item to share. Do you have anything, Tayo?
Oh, no. That was just me holding my nose, sorry.
I do love what your shout out to OIT, by the way. I think that's awesome. And I think folks could learn from that, leveraging our local universities and colleges to get talent that they need and get them to where they want to go is such a great bit of advice.
And
Yeah,
for anyone that is not already working in healthcare generally, if you're interested in getting into this space, I would highly recommend finding some way to get behind the scenes and do some work there. It defies rationality in a lot of cases. And all of it is for good reason. It's just people come in, I think, with a simple model that just isn't true. And almost always is for a good, like not always, but usually is for good reason. It's just not intuitive until you've actually been part of it. So like finding some way to get behind the scenes and do on the ground work before trying to do anything else, I think is really essential.
Great, thank you, Matt. Ryan, any last words of wisdom?
I think you guys have been covering it pretty well here. Yeah, I agree.
Great. Well, thank you, Tayo, Matt, Ryan. Really appreciate your time today. Thanks again to Skip and the crew at TAO. Skip, am I turning it back over to you?
Sure. So thank you, Molly, and the panelists for participating today. And thank you to everyone who joined us and took some time out of their schedules. We'll also be sharing this once we've got the recording up on our YouTube channel. And so for folks who love to view things asynchronously, that'll be an option. So thank you, everyone. Hope you have a good rest of your day. And as I mentioned earlier, we have one more session at noon with some startup and tech company pitches who are doing work in the digital health space. So I encourage you to check that out. Thanks, everyone.
Thank you all.
Thank you.
Thank you.